Very welcome to this international webinar. This is one of several provided in a series from the Quality of Life Working Group in Örnica. And this webinar focuses specifically on functions, feelings, families, and future with Omphalocele. It aims to give an overview of the condition and current guidelines of Omphalocele, studies addressing quality of life and mental health in children with Omphalocele and their families, and also lived experience among parents. My name is Michaela Dellenmark Blom, and I am the moderator of this webinar. I'm an associate professor and researcher at Sahlgrenska Academy, University of Gothenburg, and researcher at Karolinska Institute in Sweden. I am also the chair of the Örnica Quality of Life Working Group. And today we have the great honor to have two prominent professional speakers with us. Dr. Carmen Mesas Burgos, who is an associate professor and pediatric surgeon at Karolinska in Stockholm. She will present the latest evidence-based guideline for the management of Omphalocele developed by the multidisciplinary Örnica expert group. And also Dr. Andrew Rittman, who is a senior neuropsychologist at Erasmus Medical Center, Sophia Children's Hospital. He will present findings from his team's study on parent-reported outcomes in school-aged children treated for minor and giant Omphalocele, followed by a systematic review conducted within the Örnica network on mental health and behavioral difficulties in children with abdominal wall defects. And importantly, we also had the opportunity to listen and learn from parent and patient perspectives. We warmly welcome Linda Wallster and Tobias Aschbacher to tell their story about pregnancy, birth, health care experiences, and future perspectives. After the three speakers, you in the audience will have opportunity to ask questions, and I will do my best to moderate that. And this webinar will end at 5 p.m. Central European Time. This is also recorded, and during the webinar, I'm grateful that if you stay muted. And with that, I give the word to Carmen.
Thank you very much, Michaela, for the nice introduction and for the for organizing this important series of webinars. So I'm going to talk a little bit about what do we know, what is the latest condensed knowledge on Omphalocele. Can everybody see my screen? Perfect. And I know in this webinar today, I mean, I see a lot of Örnica familiar faces and names, but I'm aware that probably we're going to have a group of people that are not so familiar with Örnica or what Örnica is about. So I'm just going to give a very brief introduction. And Örnica, or the European Reference Networks, are a European Union initiative that tries to condensate or to get together knowledge on rare diseases across Europe and across different conditions. And Örnica is the umbrella for the European Reference Network for Inherited Gastrointestinal Anomalies, which covers several pediatric surgical conditions. And despite putting knowledge together, the aim of Örnica is also to network with different experts across Europe and across different disciplines. As Michaela was talking about, this is a multidisciplinary effort. One of the aims is to get together the existing knowledge to put together standard practices that can help clinicians all over Europe and all over the world to manage patients with rare conditions based on the best possible evidence. And one of the aims is also to disseminate knowledge, which this webinar also covers that purpose. And one of the things that is specific for Örnica and all ERNs that is very unique from other medical societies is that for us, for the ERNs, it's very important to have patient input representation, because it's not only important what we think is important, to measure, or how we should develop the care of this patient. It's the same important to know, to have the patient's input and to know how should we move forward. So this being said, I'm leading one of the working groups that focus on abdominal wall defects, and one of the rare abdominal wall defects is Omphalocele. So we put a group together of experts. Sorry, I cannot advance my screen, and I will now here. Try to gather together the existing knowledge. But one thing that is actually eye-opener, if you do a PubMed search on cancer or diabetes, you will get millions of published articles. If you do a PubMed search on, for example, Omphalocele, you will get only 2,600 articles. It's not little, but it's far from millions, meaning that these rare diseases are in some way neglected. There is not the same funding from different agencies to put money on research to develop better knowledge and better strategies. So this kind of diseases need focus from us clinicians to bring knowledge forward. So how did we go to develop this evidence-based guideline? As we mentioned, we put a group of people, not only surgeons, even if we think we are the most important people in the group. No, I'm kidding. But the same important are our maternal fetal specialists, the neonatologists, pediatricians, patients representative, but also methodologists, in order to do this in such a rigorous way as possible. And we have our star methodologist sitting in the call today, Wilhelmine, which without her this would not have been possible. And one thing we also use for the development of this guideline, because as I showed you before, I mean, there are some articles, but not as many as for all the diseases. And we usually know that when you do research on rare diseases, it's very difficult to find high quality papers. So that's why in this study, or in the development of these guidelines, we also use the EPSA registry. And what is the EPSA registry for those of you who do not know? Well, it's a quality registry that is run by Ernica, where all the centers that are members of the Ernica network share their patient data, their knowledge on the different rare diseases in a way for us to try to advance knowledge later on. So this is the big group of people that was involved in the group. As I mentioned, not only pediatric surgeons and people from across Europe, as I saw some people in some of the names and the faces in this call, like Ronnie and Alberto. And how do we usually go ahead in this process? Well, first, of course, we would like to give as many answers as possible to all possible questions, but that is actually not possible. We have to prioritize in a certain limited number of PICO questions, and out of that, look into the literature, look at the quality of those articles and what can we extract from there. And then we sit together as an expert group and try to develop recommendations that we put together in a paper. But as I mentioned, sometimes, and in this paper or in this evidence guideline, we focus on 12 different questions or PICOs. But as I mentioned before, sometimes when you look into the literature, for some of our 12 questions, we did not have data enough to be able to produce a recommendation. And that's why we use the data, the existing data in the quality EPSA registry to try to know, okay, how are people across Europe doing nowadays, and what are the results? Can we extract any conclusions from there? And then we get that together with the existing published literature, and out of there, with these mixed methods, we try to develop some recommendations. So we focus on 3 aspects on the care of Omphalocele. We focus on the prenatal care, the immediate postnatal care, and the closure, the surgical closure of the abdominal wall. And as you see, this doesn't cover much of the long term. That is something we should add on later on in our further studies. But we have, as I mentioned, we have to be pragmatical and focus our question to a manageable number of questions. So for the prenatal care, our recommendation is that all patients should be offered the most advanced genetic testing available in the country. At the moment, the most advanced is whole exome sequencing. Not all hospitals will offer that, but when it's available, we recommend that. Even if there's very few studies, only 3, and there is no data on the quality registry at the moment because this whole exome sequence is quite new. Our recommendation is weak because we cannot force all hospitals to afford this kind of technology, but when available, we recommend that all parents should be offered the most advanced genetic testing available. We also recommend to deliver vaginally, not doing C-section for the non-giant omphalocele, unless there is other maternal indication. And our recommendation here is strong, even if there is only one article that we found in the literature. Why is that? Well, because it doesn't seem to be, according to the EPSA data, doesn't seem to be detrimental for the baby to be born vaginally if you don't have a giant omphalocele, and we want to spare a surgery for the mother. Another recommendation is, as an obstetrician or maternal fetal medicine, you should look into liver herniation at the second trimester because it's associated with a bigger omphalocele. Then even if we only include 5 articles, we did not have enough data in the quality registry, so it was difficult to set a cutoff of if we meant 50% or 70% of the liver, or how much of the liver should be herniated to call it giant. But we know it's a sign of a bigger omphalocele. The same goes to the measurement of the omphalocele and abdominal circumference ratio. How big is the omphalocele compared to how big is the rest of the abdomen? Because it will also give us an indication on how much is outside of the abdominal content. Here, even if there are several studies on the matter, we could not really give a cutoff on, okay, is 1.2 the same as giant, or is the cutoff in 1 or 0.8, because there was not data enough. But we strongly believe that if we can prospectively keep on collecting data in the EPSA registry, in some years we will be able to give some cutoff on at which ratio we should call it giant. We also recommend that for giant omphalocele, you should do a prenatal MRI to measure the lung volumes, because we know that giant omphalocele are associated with pulmonary hypoplasia, and it's good to know for the neonatologist taking care of the baby after birth how severe we can expect the respiratory function to be in these children. If we move on to the immediate postnatal care, we do recommend to start enteral feeding as soon as the patient tolerates. And if you see here, there is 0 studies included, but our recommendation is strong. Why is that? Well, because there is enough data in the registry showing non-detrimental effect that when you start early feeds in the baby with omphalocele, doesn't lead to any other complications. And then we believe that will give as a follow-up will be lower needs of parenteral nutrition on central line and central lines infection. And we also know that this is very important for the parents, so that's why our recommendation here was higher up to strong. And this is what I mean about how important it is to get the input from parents when we do this kind of work. We also look into the possibility to do not intubate the babies when we are doing the stage reduction. And by stage reduction, we also have to keep the different names straight. What we mean by the stage reduction is when the omphalocele is too big to close immediately, that you have to slowly put everything down. Not every patient might need intubation. So even if it's, again, no studies that are looking into this, there is enough EPSA data showing that in those patients that this has been attempted, has not been any complications. And we know that, it's better not to be intubated than to be intubated. So for the patients that tolerate this, and not everybody will tolerate, but for the patients who tolerate this, and then we have a good assessment on the comfort scale and so on for the patient, that could be a temp. Then we move on to the jungle of how we closure the abdominal wall. And this is really, this was very difficult to come up with any fair conclusions in many topics. But in one of the topics, if we are comparing, now we're talking giant omphalocele. So if we are comparing, either we go for stage reduction, meaning that we try to push in everything slowly, or we try to paint and wait, delayed closure. Well, we couldn't see that one method was better than the other, but if the patient suffers from pulmonary hyperplasia or pulmonary hypertension, we strongly recommend that you should not try to close the abdomen. You should try to let it cover by skin and deal with the ventral hernia later on in life. If you are using the paint and wait, the delayed closure method, we strongly recommend not to use some topical substances that can be potentially hazardous, like metochrome, silver solutions, or povidone. We will recommend honey or silver compresses. When we come, okay, let's say we have a giant or half giant omphalocele, and you think your baby tolerate that everything gets back to the abdomen and you can close within the first hospital visit. Which technique to use? Duoderm, Silo, fasciotens, tapering, we don't know. Here was a real jungle of different strategies, and we cannot recommend for one or the other. Our only recommendation is you should do what you have most experience with and what you are more used with. Then when we come to the timing of closure for the smaller ones, the smaller omphalocele, well, this is not a surgical emergency. The patient can wait overnight until the day after. They can even wait over the weekend and be done in daytime with a proper surgical and anesthesiological team in place. How do we do with the patients that we opt for paint and wait, meaning delayed closure? When are we going to finally deal with the big hernia? Well, it's no hurry. It should not be before 1 year of age. There is no benefit of doing that before. There is no detrimental effect of doing that earlier. But we have to take into considerations that parents might push for a earlier closure because, I mean, it's convenient to have everything done when the kid is going to start daycare and so on. But from the medical physiological point of view, it's no rush to do it before 1 year of age. And this is the part of the multidisciplinary group that work with this. This is all I have to say so far. So I will leave the work to Andre, and I will happy to take some questions later on.
Thank you very much, Carmen. And I will share my presentation and hope you can see it now. And I go towards the presentation mode. I'm Andre Rietman. I'm a mental health psychologist and assistant professor in Rotterdam, the Netherlands, at the Erasmus Medical Center, Sophia Children's Hospital. And I hope to tell you something about quality of life and mental health in children born with omphalocele. And next to our own findings, I will combine that with some recent studies that have been performed not in our center, but to give you a more full update on this topic. And as Carmen already said, there's sparse literature, so I hope to tell you what we do know. And one of the groups that is quite active is our group who already have a running structured follow-up since more than 25 years. And we see children in this follow-up at fixed ages. So as you can see, at 2, 5, 8, 12, and 17 years. And Annelieke Heikoop did her PhD mainly on abdominal wall defects. And she described this group, if it's about the children born between 2000 and 2012, both the children themselves, because we look at their development at a young age and at a later age. And we ask the parents also to complete questionnaires on quality of life and emotional and behavioral issues in the children. Over these 12 years, we had 54 children eligible, and 60% of them almost returned the questionnaires, leaving us with a group of children ranging from 5 to 17 years old, of which 1/3 had a giant omphalocele, and you can see the reference below. First, she published, Annelieke, in our group about the development at a young age. We use the Bailey scales of infant development for that, and here you can see that there are some children with delays, but we see that in a general population as well. And since the proportion of the children, if it's about mental or cognitive development, is largest in normal, we um, conclude here that the cognitive development generally is quite normal in at 2.5 years, but we do see a big difference for the children if we compare the ones with a minor and a giant omphalocele. And as you can see, um, the on this side, there are a lot of children who have a normal motor development at 2.5 years when they have a minor omphalocele, but the children with a giant omphalocele are mainly spread over the categories where we can speak about a mild to severe delay. So this is an effect that we do find for motor development, but not for cognitive development. And later on, we also looked if this was predictive of these ratings, which is, as I said, for a group of children of 9 years old. And to the left, you see the results of a questionnaire on quality of life, the DUX, which is a more subjective questionnaire asking about parents' feelings about how happy children are with their lives. And you can see that if we compare the children with omphalocele, that is mixed giant and minor omphalocele, with matched controls, which is a group that is twice as big but matched on age and sex, that there is not a very big difference. The blocks all overlap, as you can see in all three the graphs. So we conclude here that both quality of life and health status, and also emotional and behavioral problems, are not really different from the control group. We did an active control group because we also gathered norms for the Netherlands for these specific questionnaires, and which reassured us and also made us decide that we don't do a structured follow-up of these children anymore. So we mainly look at their mental health and quality of life if there's an indication set by either the worries of the patients or the school, or the pediatrician who is seeing the children yearly. And this is about our research, but there are two more recent studies, one in 2024 in Germany with, again, a small group, that in fact confirmed our findings. They also didn't find significant differences on a questionnaire for quality of life, but that was a group that had a similar age as our group, so between 5 and 9 years old. But if we look at more younger children in a really large group in a recent Chinese study published this year, we can see that there is perhaps something to worry if we look at the children between 1 and 24 months, so the first 2 years, because there we find total scores that are lower in the children or the parents of children with omphalocele, mainly on physical function, physical symptoms, emotional functioning, and cognitive functioning. Possibly that has to do with obviously the somatic part where Carmen already told so much about. And these children really need these first 2 years to, in fact, settle, and this probably is the cause for this lowered quality of life. But what is reassuring, although this is not a longitudinal but a cross-sectional study, at the age of 2 to 4 years, these total scores for physical, emotional, social functioning are higher or the same in patients than in the healthy controls. And there are some predictors for the total score, which is age, obviously, because we see these issues at 0 to 2 years, but not 2 to 4 years, but also the presence of other malformations. Carmen already mentioned, for instance, the pulmonary aplasia, which could contribute to a lowered quality of life. And if we counsel parents on the long run, they also have questions about the rests of the symptoms and also the scars. And for that, it is perhaps interesting to refer to a recent study where patients and parents are asked to complete a skill about their skin and their scar, because this is a worry of a lot of patients and parents, whether that will give some problems on the long run. And it's perhaps again reassuring that the scores on the subjective appraisal of the scar and of the skin is not related to quality of life. So in fact, those are two things, and people can have a really good quality of life, even though they rate their scars as visible, for instance. So the conclusions that we draw from quality of life is that at 0 to 2, we find lower scores. But then again, at 2 to 4, that seems to recover, although it's hard to say when it's not a longitudinal study. And at school age, both the Dutch study from us and the German study, there we can see that quality of life, health status, but also cognition and motor function are comparable to those of healthy children. And we conclude that children with an isolated minor omphalocele do not need extensive long-term follow-up, but the children with giant omphalocele, they do have risks for delayed motor functioning, and we do recommend long-term follow-up for them to offer timely intervention, for instance, physical or occupational therapy when necessary. And I'd like to jump towards mental health, because our group, the Ernica Quality of Life Working Group, and mainly one of the students of Michaela Delemark, Sarah Persson, did a really big job on reviewing in a very systematic way the mental health and behavioral difficulties in children with a variety of gastrointestinal surgical conditions, amongst which also abdominal wall defects. And as Carmen already addressed, although we looked in 6 databases, we only found 46 unique articles in quite a long period of almost 30 years. And 9 of them were on abdominal wall defects, and 3 of them on only omphalocele, and 3 of them on both gastroschisis and omphalocele. We conclude from that in the paper that is not yet published, and we do hope to publish it this year. We found that 5% of the children had abnormal total difficulty score as measured with the SDQ, which is this questionnaire for parents about emotional and behavioral problems such as hyperactivity, anxiety, mood problems, etc. And if we look more closely towards the scores that are a bit deviant but not in a clinical range, we found 30% of the children with higher internalizing problems, which means mainly problems in the areas of anxiety, depression, and withdrawn behavior. 20% in externalizing, which mainly refers to, for instance, oppositional, defiant, and aggressive or hyperactive behavior. And 20% of the children have behavioral issues at the age of 5 years. One very clear finding is that some studies looked at autism, and they found a range of 13 to 23% of the children with giant omphalocele with autism. And none of the children had ADHD, and perhaps 13 to 23 doesn't sound much, but if you know that the population prevalence of autism is quite low, is between 1 and 2%, then you see that this is a 10 to 20-fold amount of children with autism that have also a giant omphalocele. And to end this, I'd like to make a little bridge towards the parents that are going to tell their story, because I found a really recent Canadian study about mental health outcomes of mothers of children with congenital gastrointestinal anomalies. This was a really large population study with 780 children, mothers of children, of which 61 with an omphalocele. And they did a good job in using a standardized coding system for mental health. And they found that most mothers are not at an increased risk of mental health disorders if we compare them to controls. And there's not an increased risk of anxiety, depression, or post-traumatic stress disorder. But, however, omphalocele is associated with mental health diagnosis in mothers before childbirth, and possibly that has to do with medication that has been that is being prescribed for parents and also mothers, obviously, with anxiety and depression. Those are the selective serotonin reuptake inhibitors, and this has been associated with congenital anomalies such as omphalocele. And this increased likelihood of omphalocele mothers being diagnosed with mental health disorders prior to birth provides additional evidence for this association. So that's something to look at, to be aware of if we counsel the mothers of these children. I'd like to end my talk with a thank you to my departments and my colleagues, and I'd like to give the words back to the parents that will share their story. Linda and Tobias.
Thank you very much, Andre. So we can just do a brief introduction. Tobias and Linda, we live in Sweden. We have a soon-to-be 6-year-old son, Nemo, who was born with a giant omphalocele. And as we have understood throughout the first period of time when he was born, it was one of the larger omphalocele that the doctors had experienced. It's been a very bumpy ride, and he still doesn't have a final closure yet. So there's still more to do. But would like to share story back from when we were pregnant and then trying to come up to today. So Linda will start explaining that, and I will share her screen right now.
Okay. Yeah, I'm going to start with the time during pregnancy. So at our 12-week ultrasound, our world changed. That was when we first heard about Nemo's omphalocele. We left the appointment in shock with very little information, trying to understand words we had never heard before. The fear of the unknown was overwhelming. What would that mean for our baby, for our future? The weeks that followed were filled with hospital visits, tests for trisomy 13, 18, and 21, and long conversation with surgeons. Each appointment brought new answers and new worries. Then we learned that Nemo also had a heart condition, an ASD, more uncertainty, more waiting. There were a lot of feelings, fear, sadness, hope, and love all at once. The hospital staff gently explained that a late termination was an option. They arranged for us to speak with a psychologist to help us face the most difficult decision of our lives, either to continue the pregnancy or to let him go. We asked about his chances of survival. We got 60%, 40% against. And somehow that was enough. When we heard that his chance of survival was greater than 50%, everything became clear. Through all the fear and uncertainty, one thing was stronger than anything else: our love for him. In our hearts, we knew we wanted to continue the pregnancy. Birth. This C-section was planned, but nothing could prepare us for the fear. When Nemo was born, everything happened so fast. The team took him straight into another room. I didn't get to see him. I didn't get to hold him. Tobias was able to cut the umbilical cord, a small but meaningful moment of normality in the middle of everything that felt anything but normal. A nurse took a picture of Nemo and showed to me. That photo became everything. I couldn't stop looking at it. It was the only way I could feel close to him. I didn't get to meet Nemo until 3 hours after he was born. 3 endless hours I felt like a lifetime. Then they rolled my bed into the intense care unit. The room was filled with machines and monitors. Nemo was on a ventilator with IV lines everywhere. It was heartbreaking to see, but he was there. He was alive. And finally, in that moment, despite everything, we were a family. And 3 weeks after that, I could hold him in my arms for the first time. Struggle in the hospital. We slowly got used to the hospital, but nothing could have prepared us for what came next. On day 3, Nemo needed emergency heart surgery. The doctor told us he might not survive. We had to decide on a name, and we wanted a priest to baptize him. I just remember saying, no, this can't be happening. Seeing the doctor holding back tears, it broke us. We called our parents. We needed them to hold us up because we couldn't stand on our own. I will never forget the heart surgeon walking into Nemo's room before the big surgery. He was calm, confident. He had his backpack on, saying, "This will go well." Somehow his calm steadied us in the chaos. And then the long wait was unbearable. We were exhausted, heartbroken, terrified. Our parents were there, and the psychologist helped us hold us together. Then the call came. Nemo had survived. Relief, gratitude, love, it flooded through us. That day, we learned what true heroes truly look like. We stayed on a different floor than Nemo in the beginning, and every time we entered his room, the first question was, "Is he stable? How was the night?" The fear never left us. The nurses pushed us to take short walks outside. Those few minutes of fresh air saved us. But what truly saved us was the love around us, the nurses who became our family, our parents, and Nemo himself. His joy, even in pain, he carried us. Being in the hospital during COVID was lonely. No visitors were allowed. And moving from intense care to the regular surgery floor was another test. Machines were removed one by one. Back and forth we went between ICU and floor 11. When we finally got our own room, we were scared. Were we ready to take care of him alone? Play therapy and small moments of joy taught us to live in the moment. When Nemo was 5 months old, we were allowed to take Nemo home. It took over 1 hour just to get him into the car, disconnecting his breathing aid for a few seconds, dealing with a leaking stoma bag. I sat in the back seat with him, trying to keep him calm while panic surged inside me. After only 5 hours, the unthinkable happened. Nemo struggled to breathe. We called after an ambulance, but they let us take the lead because we knew him the best. I held him in my arms, gave oxygen, and sang his favorite song over and over. At the hospital, we learned that it wasn't Nemo, it was his equipment that had failed. Later, the head of the lung clinic called us to apologize and explained that new safety routines had been put in place. Through all the fear, exhaustion, and pain, love held us together. Nemo showed us courage, and we will never forget the heroes who stood with us, the doctors, the nurses, our families, and above all, Nemo himself.
So I can go on speaking about the time after we were at hospital. We still needed a lot of care for Nemo, so we took care of him a lot from home. This meant that Linda in a total, she was outside of work for 5 years. So you started work this past year again, 9 months back, and it's been challenging, but slowly getting there. I was off work for 1 entire year. I have the freedom to work from home, which is a huge benefit, and a very understanding boss, which is great. But there's still like a lot of work to do to be able to report sick days for Nemo to the authorities. The financial situation is really pressed when both parents can't work, when we both took care of him in the hospital and after the post-time hospital at home. So as we live in Sweden, we are quite lucky to have a backup system, merely making it, but it's still there. So the first time after staying 6 months in the hospital, when we were staying at home, we were very thorough that we wanted to be able to take care of Nima on our own. So we were sent home with, like Linda mentioned, like the breathing aid. We had extra oxygen. He had special feeding. He also had a stoma, which was unlikely that he developed a stoma through a operation when he was 2 to 3 months old. So it was a lot of work. And although we got home, we had checkups like 3 to 4 times a week. So there was a lot of going back and forth to the hospital from home. Nemo went off his oxygen when he was basically 1 year old, and then he had a high flow cannula up until maybe a few months later. He had special needs for feeding, so we were really struggling with getting him to gain weight. But we finally got there. What we felt for that time was that we were a bit forgotten from the healthcare system. When we were discharged, the surgeons that took care of Nemo back then, they didn't have a initial plan for his future operations. We felt really left out, so we tried to search as much info as possible on our own. We even considered changing hospitals or looking elsewhere. And then we found out that another surgeon had treated a female with a similar omphalocele size to Nemo's. So we were lucky enough that she joined forces with Carmen at the hospital in Stockholm. And I think it was back in 2022 when we got contact with Carmen, this other surgeon. We were on the right track again. So that made all the change in the world. We felt safe again, and we got the right info, and people could listen to us. And balancing the normal life alongside with healthcare is really hard. Nemo could not go to daycare. We were in quarantine a lot because of his risks for infections. He was really sensitive. As we had a lot of equipment in the beginning, we had to rebuild the stroller so we could equip it with oxygen and his high flow cannula, for example. Going back and forth to the hospital with the car, we had to install a special battery so we didn't lose any flow in the cannula when we switched him over from the house over to the car. So we had to be really like curious how to solve problems in order to get a normal life as normal as possible. And it's always been our intention that we wanted to learn as much as possible from the staff at the hospital. How can we take care of our son on our own, not to be reliant on healthcare too much. One thing that really hits you hard when you have a child that needs this sort of care at home is the lack of sleep, and especially for my wife. As Nima had a quite advanced stoma, it was a lot of work with this stoma bag. I think for like 2 years you had lack of sleep. You had to empty the bag like every other hour. So it's remarkable how much you taken on when you look back. However, yeah, you sort of adapt, although it's really hard. It's always been a challenge for Nemo to eat when he was young. We were always trying to push him hard on that scale, and it's I think we ended up like with IV feeding at home. We had to train ourselves to be able to give him IV nutrition, so you could get up to pace there. Our son has always been a lot into cars, which is great. So he's built an interest around that. So we found a organization in Sweden called Lean on Me, and they organize a track day like every year for kids that had a really tough start in life. So you can go there and you can ride in cars, you can ride in excavators, helicopters, and everything. So it's really nice that they organize happenings like this, and we always remind Nemo that he has to be careful with his stomach because he still doesn't have any closure. He's adapted to that. He started preschool when he was 4.5 years old, which is fantastic. And the first year was really, really challenging for us to be able to let go of him more and more. But we've been lucky with the people working with him there. They understand our needs. We've slowly been able to give him the option to, be more free. He has a corset that really protects his stomach, and he also has like a hard shell when he's outdoors. So we got that equipment, which has helped a lot. So he's in our world, he's getting more normal every day, which is nice. So I guess Linda would like to speak about something really important, and that's because we've had really challenging work with Nima at the hospital. He was, when he was around 2.5 years old, he was really, really scared of hospitals. So how challenged that?
Yeah, so we're constantly working to prevent Nemo from developing a fear of hospitals. So for one thing, we started calling the operation room, surgery, to Hatland, almost like Disneyland, but Hatland. It's because the surgical team, they wear funny hats. And, it makes the hospital a little less scary and a lot more magical. So we even wrote a song about Hatland and made a little music video. So every time Nemo has to go to Hatland, we play a song and a video for him. And it makes him excited, calm, and ready for the visit. You're turning something scary into something fun. And also the play therapy at the hospital, it's very important for Nemo and also for us. After every appointment, we always visit the play therapy before leaving. This helps Nemo remember the fun parts of the hospital, not just the treatments.
Yeah, and I can just add on as well. I'm just jumping back in time a little bit here, but when Nemo was in need of the most intense care when he was really young, he suffered vastly from withdrawal from all the drugs he was on. It took probably 2 months in order to get him off all the heavy drugs. And this is really something that you as a parent would never be able to imagine when you go into healthcare. Many of the doctors said that, like, in a normal case, it would be quite easy, but Nemo has proved from time to time that he's not in a normal case. It's always quite special. So our concern and our fear has been throughout the years, how has this been, what's the effect in the long term, for example? So far, we really haven't seen anything. We don't know if he will have any any phantom pain or something in the future. But it's something that you think back and may have triggered a lot of hospital fear then. So it's really important for us to continue to cheer for him when he's in the hospital, to make everything positive. One example is that, like, after every hospital visit, because it could be quite tough things that we did quite often, was that we always went to McDonald's afterwards, as he tend to like the nuggets and the burgers, just to make a positive note of it. Nemo talks a lot about the hospital. I mean, it's been our second home throughout the years. Strange when you get back there and you go into care, it's like it feels like home because of all the fantastic staff and everything. So it's really important that we keep going back and reminding him that it's a positive place to be at, especially the play therapy section. They're fantastic with him. So one more important thing is that as Nemo's stomach is different, all the kids with Omphalocele are going to have scars, and in his case, it's a belly that sticks out a lot at the moment. We always tell him that your stomach is beautiful, and he thinks so too. It's a positive way. Right now, when we're going into the next step, maybe later on this year, we're trying to say that we're going to make your belly stronger, so it's going to sink in a bit. So he's prepared for that. As he's turning 6 years old, he's understanding more and more. And I guess the most important thing is throughout hard and really painful treatments from time to time, we as parents stay perfectly calm outwards. Maybe we're burning inside, but we've always been a team and being really, calm for Nemo when he looks at us, and we offer him the security. Just to end things off here, then, like the future procedures, like I told, we have a quite large surgery coming up for Nemo. Maybe it will take place in a few months or in the fall. We're both scared and optimistic about it. As he turns 6 years old, he understands more and more, so he's asking us more and more questions. We don't want to keep anything back, so we'll answer the questions he has, but also we have to keep our answers in a level that he understands and makes a positive sense of the hospital care. And he often refers to, like Linda said, the Headland when he's going back to the OR, for example. So he's really positive about that. The staff there's terrific. They always have the big screens. He can watch Monster Jam with monster trucks that he loves and everything. So it's a good thing. Right now, I mean, we're feeling like a normal family, although we have the major surgery coming up. Nemo has a younger brother. They give each other a lot of love and whatnot, like brothers do. So we have to remind ourselves that it's a really healthy sign from Nemo. He will start elementary school soon too, which is fantastic. Just at the end here, we can say that the people that understand us the most when we're in, quite severe healthcare is other families, other children who are in similar situations. So we've met, a lot of other folks throughout the years that we have contact with, and new friends for Nemo as well. So That's really nice. So that's like wrapping up our like 6-year story in maybe 15 minutes. But yeah, there you have it.
Thank you so much. I really want to thank all speakers for their contributions, and I'm quite confident that there's a lot of thoughts and reflections in the group. We have a few minutes left, and I'd like to open up for questions. The audience can put questions in the chat, and you can raise hand, and I will try to moderate the discussion. So please, anyone, if you'd like to ask the speakers anything. Okay. No one yet, but I have a question. So, thinking that literature is really sparse, especially in some areas, but there seems to be some indications of the future needs, which we can also trace in Linda's and Tobias' lived experiences. And in this group, we probably also have a lot of clinical experiences. So how should this group of children be followed up in healthcare and their families? What are the opinions about this? Carmen, what do you think?
Yeah, that is the challenge, because it's a very spread group, as André was showing. The smaller omphalocele most likely will not even know that they were born with a minor defect, while the middle ones might have some challenges and the giant ones might have additional challenges. So I think we have, even if we have become better and better to try to develop standardized treatment strategies, standardized follow-up programs, we still have to keep in mind to have a patient-tailored approach. What is best for these patients? So I think we should start off with a minimum requirement and then adapt that depending on the needs of the patient. And that is one of the challenges, because as I mentioned before, abdominal wall defects have been a little bit of the neglected kind of diagnosis within pediatric surgery, because for the majority of the patients it will go well, but we don't have a system to capture those that need help. It's very much up to the parents to search help, for clinicians, of course, not to let go when things are not still functioning well, but there is not the same structure follow-up as it is for other conditions. So I don't know if this is an answer for your question, but at least we should have a minimum requirements, and then we should add on depending on the needs. But we should, all our patients should be our umbrella, under our umbrella, until they are small adults, and then they will need our help more or less under their growing up period. But they should be under our umbrella in somehow, because sometimes, I mean, it's difficult for a child to acknowledge some complaints if it always have felt that way, if you are born with that condition. So we should be more active in following our children, even those who don't need, because those who don't need, I mean, it will sort it out. I don't know if it was a good answer, but yeah.
Yes, I think it was. And I think it stresses the importance of not losing track of them. And so they know also where to turn, and that there's a minimum and criteria for follow-up, but also individual adaptation. So I can see that Nils Kvist want to make input. Please go ahead.
Yes, can you hear me now?
Yep.
Yeah.
Yep.
But I think what we have heard today, and what I also experience in my lifelong clinical work, is that we don't take enough care of the parents. And this is really a missing link. And actually we have found in a small patient series from our hospital that the divorce rate among parents were much higher than the background population. So I think what is important is also to assist and to help the parents. That's very important, and and our healthcare system doesn't take this into account in a significant degree.
Yeah, I do agree
Roni?
with that, Niels, because, sorry, can I
No.
chip
Okay.
in, Michaela?
Yeah. Yes. And then
Because I want
next
to
after
make
Roni.
one reference towards something new that's coming up. I really agree with the fact that we need to take care of the parents, and there is in EURORDIS, which is the European Patient Organization for a real large diversity of patient organizations, a mental health initiative, and we did some reviews regarding psychosocial care for patients and parents with rare disease. And there will be 2 grey literature publications in the coming month. So if you look up EURORDIS and mental health, I try to put a link in the chat, then you can find something more about psychosocial support. And I would really recommend all people just such as Willemijn and Carmen, who are devising these guidelines, to also add a psychosocial part to these guidelines. Although there is this sparse literature, there is literature about caring for parents in some rare disease, be it not Omphalocele, but we do know more than nothing.
Yeah. So I think Carmen already mentioned at the beginning there will be a plan for the follow-up part.
Yes.
Roni,
Yes. One quick comment. I'm partially agree with Niels, because I think that parents, first need of parents is confidence in the medical teams, and everything started in the prenatal counseling meeting. I really insist too much on this first meeting with the parents, and I think that we can prepare many things with this counseling meeting, like, for example, visit the intensive care, just to visit the walls and the rooms. It's very, very helpful. And for giant omphalocele, I'm talking, sorry. I really, in my head, it's 2 different diseases. For giant omphalocele, we need to have a long relation with parents, because, as we all said, we need to a long-term follow-up, and we need to have a nice relation with them and confidence from both sides. Many of these giant omphalocele are not operated. The majority are done before 1 year of age, but for a huge case, for associated abnormality case, we have many children at 4, 5, 6 years old, not closed from the abdomen yet. And we really need this long relation and confident relation. So that's my comments on how to deal with parents. And second comment is that giant omphalocele, we have a chance in France that we can add it in the reference center of congenital diaphragmatic hernia via the pulmonary hypoplasia. And when we have reference centers, official reference centers in the city or in the town, it also helps to schedule the long-term follow-up and even to prepare the transition. So I think these 2 points are very important. Reference centers, known reference centers for all the population, and a wonderful relation with the parents who started during the pregnancy.
thank you, Roni. So with that, I will let Linda and Tobias make the last comments for this webinar, although I recognize there are many things we could discuss, because you shared a very touching story, I must say, and a lot of experiences. How would you say that parents need to be taken care about? What should we think about?
Yeah, it's interesting. Like Niels mentioned that divorce rates are higher. It's like when we come back to the hospital, I remember a few years back when we hadn't been there for a few years, the staff said, "Oh, you're still together," like they were surprised. So I mean, we understand that, and of course, all parents are unique, and I guess you have to go in as a team together, really hard. What I think we needed more, like prior to birth and stuff like that. We got a lot of facts, hit on us. We didn't know what Omphalocele was. We had to Google it, of course, to understand. There was like really no plan whatsoever, for our feelings. Everything was like, yeah, you can terminate or not or whatever. So the decisions, prior to birth was the hardest ones, I guess.
Yeah. Sorry, it's so lost. It's hard to say.
I think like when Nemo was 3 years old, that's like the first time we got the information that we could get grown-up counseling from a psychologist from the hospital care. I mean, we had a counselor when we were like in the ICU and stuff like that, which was great, but not after we got home and facing all those challenges with like lack of sleep. And okay, for us, as it was our firstborn, we thought that was the normal life. And then when you get a healthy younger brother born, understand that okay, it was really tough. So I think you need to address parents in the hospital and offer them the best like psychiatrist you can give or whatever. So yeah.
Okay, thank you so much. So now we passed time, so we needed to close this webinar. But I encourage also the audience, if you have input or would like to have more webinars on related topics, to contact the Örnsköldsvik Quality of Life Working Group, and we can arrange more. I'd like to thank all of those who joined this webinar and all the speakers again. And with that, I close the webinar.